Okay, so let me just recap some of the key things we talked about treatment. One of the things I think it's confusing people is like, well, what if I have a patient with leaky gut? Shouldn't I start there? Why should I jump to all these other things that we're talking about versus fixing a leaky gut or really working on another clinical factor? Maybe it's a adrenal related issue. Maybe it's thyroid conversion issue. You should absolutely do all those things. You have to fix what you have to find. You fix what you find. And that's the key thing that you want to understand is you still go through the process of all the physiological mechanism interactions. The key thing is, though, if you can get people to have a circadian rhythm, if you have people to move, you're going to make mitochondria. So even if you're trying to fix their leaky gut, you're going to get mitochondria improvement in their enterocytes so they can recover faster. Even if you're trying to deal with a Hashimoto's issue or a thyroid issue or whatever the case may be, you're going to help the recovery if their mitochondria biogenesis pathways are more efficient, if their fusion-fission pathways are more efficient. So the little diagram I gave you in the treatment can overlap against everything else that you're doing, but those are areas that are overlooked that then get in the way of patients being able to recover. So it's not like you do one or the other. You just have to have understanding of those mitochondrial pathways that we just went over in a combination to what your clinical workup is, see where they merge, and then apply the clinical concepts. And the key thing is that when you're dealing with chronic disease is a multivariate model. It's not like one simple variable that's causing the issues. It's a complex web of many things all going wrong all at the same time, and you're trying to untangle that and get them to function. The more efficient you can hit those ATP bioenergetic pathways, the faster, more efficient the recovery. So you want to make sure you haven't overlooked their sleep and focused into how they sleep. You haven't overlooked how important movement is for them in order to be able to recover. You haven't overlooked and taken their blood sugar handling system seriously enough to really have them have stable energy. You haven't overlooked missing their wheezing and have asthma, and you're trying to fix your leaky gut, which is not going to respond very well until you get mitochondria working, and their wheezing from asthma is causing hypoxia, so you can't make those types of changes. So the point of everything we talked about so far is just to know how important these little steps are, and these little steps sometimes make the biggest difference between a chronic patient turning around and not turning around. Okay, it's not related to a new magic protocol or new intervention. It's the very obvious that everyone knows that gets ignored when we get into a real clinical setting. So those are the things that hopefully sink in when we get into that. We'll go into the treatment approach. Now, what we're transitioning in this course is from fatigue to depression and pain syndromes, and we're going to spend a lot of time on pain tomorrow. And there's a lot of connections between lack of bioenergetics and pain, and then depression and other types of conditions. And these things are really important to understand. And really not just so for your patients, but for yourself. As you go through this course, you should really ask yourself, how is your energy? If your energy is low, it is a problem. It's going to cause health problems for you down the road because your body's ability to attain homeostasis is compromised. And I'll show you some papers now. It's going to be linked to cardiovascular disease, linked to cancers, linked to neurodegenerative diseases, linked to inability to recover from musculoskeletal issues. So your energy levels and your loved ones' energy levels, the people in your inner circle, not even in your practice yet, their energy levels all really, really matter. So when you see fatigue and fluctuations of energy, you really need to get to the bottom of it to optimize health. It is a serious issue. Now, where we are right now is now we're going to talk about the connection between fatigue, depression, and pain syndromes. So the academic objective of this presentation is to review how impaired mitochondria bioenergetics impact common chief complaints of patients. And then the clinical objective of this presentation is to understand the mechanisms of how mitochondrial bioenergetic imbalances lead to systemic pathophysiology. So we spent some time going over fatigue syndromes. We talked about all the things that impact the steps of mitochondrial homeostasis, things that negatively impact it, things that positively impact it, weighing in disruptive versus supportive mechanisms, shifting things to people into a more supportive than destructive pathway to improve energy. And those are all related to fatigue. Well, how does that relate to pain? and pain syndromes. Well, let me share some studies with you and show you these relationships. But to give you a clue, there's some mitochondrial involvement with these as well. So this is a paper that was titled Chronic Pain is Common in Mitochondrial Disease. So we conducted a survey of pain syndromes in patients with genetically confirmed mitochondrial disease from 2 UK mitochondrial disease specialist centers. The majority, 66.7% of patients, had chronic pain, which was primarily of neuropathic nature. So mitochondrial disease, the majority of patients will end up with pain. And that's that's why you see in your practice all the time. I'm so tired, and this hurts all the time, whether it's headaches, whether it's injury that isn't recovering, whether the body just aches, whether they work out and just can't recover. Those are all in the realm of pain. And then here's another paper that was Is Fibromyalgia Muscle Disorder? Histological studies, particularly on electron microscopy, abnormalities in the number and shape of mitochondria have been identified. So mitochondrial abnormalities, reduced capillary circulation, thickened capillary endothelium may result in decreased availability of oxygen, impaired oxygen phosphorus, as well as ATP synthesis. So the patient had fibromyalgia where the muscles hurt all the time, and there's always an ache there. They basically do a muscle biopsy, look at it, electron microscope, and see, yeah, well, their mitochondria does not work. Now, when we look at a key pathway here, this is something we went over before in the neuroinflammatory course. But you have to understand that mitochondria use glucose, use oxygen, they get stimulation to support mitochondrial biogenesis to make ATP. And then inflammatory oxidative stress responses uncouple them. But if you have, let's say on the left-hand side, the ideal response, where the mitochondria are getting plenty of stable, healthy glucose, oxygen, and activation, and they're able to quench their oxidative stress, free radicals with antioxidants, then there's good ATP. And what happens when there's good ATP is that impacts the sodium-potassium pump and resting membrane potentials to threshold. So remember, neurons are all firing at a certain degree of activity at all time. That's called the resting membrane potential. And there's an all or none phenomena where you have to have a certain amount of activity to actually reach threshold to then cause a response. And when you activate a pathway, let's talk about a pain pathway. When you activate a pain pathway, you get an influx of sodium into the cell, and you also get an influx of calcium into the cell. And that influx of sodium and calcium to the cell take that resting membrane potential to the threshold. And if it's a nociceptor pain fiber, then you feel pain. And that's a normal physiological response. Now, what happens when mitochondria are impaired, where, for example, if there's lack of oxygen from anemia or poor circulation, or decreased glucose from dysglycemia, or lack of activity impacting mitochondrial biogenesis, or increased inflammatory response where the mitochondria become unhealthy and there's less ATP, what happens is when that pain fiber fires, and there's this influx of sodium in, which takes the resting membrane potential to threshold, there's not enough energy within the cell to push that sodium and calcium out. So that leads to neurons that are really close to threshold. When neurons are really close to threshold, then any trivial stimulus can then cause pain. So now you have a person who, instead of having a sharp pinprick cause pain, just touching them can cause pain. Those neurons are close to threshold. This is one aspect of several we'll talk about that leads to increased pain perception. But the basic concept is when there's mitochondrial impairment and cells do not have healthy amounts of ATP, they cannot maintain their neuron resting membrane potentials close to threshold, and then any trivial type of stimulus can fire them because their distance between the rest and threshold levels are now closer together, as you can see here, compared to this. So if you look at a pain pathway, you have a needle here pricking their skin here, fires into their ascending pain pathway, it's perceived as pain. And in a situation where like everything is normal, then everything's healthy, there's a normal response that's taking place. And if we continue on here, this is what we're seeing. Neurons, resting membrane potential is far away from threshold. It's normal to have pinprick cause some sensation that's protective in a sense. It's helpful for us to move away from the injury. But when the mitochondria become impaired, then what starts to happen is the resting membrane potential is really close to threshold. So there is instead of having this normal response to activating pain pathways, neurons get close to threshold and they have significant activation of pain with trivial stimulus. And this is one of the reasons where mitochondria and pain pathways are so linked, is that these nociceptors become close to threshold. And when they study mitochondria, and it's not just sodium, but it's calcium. So calcium also gets activated into the cell and has to be pushed out through an active transport pathway out of the cell for depolarization. And when there's not enough ATP to push that calcium out, then you can have people that have pain syndromes and pain disorders. So here's a paper that was published called Contribution of Mitochondria to Pain and Diabetic Neuropathy. In conclusion, impaired calcium homeostasis due to mitochondrial dysfunction is a factor related to diabetic neuropathy, with findings showing increased intracellular concentrations and an imbalance in calcium transport in dorsal ganglion neurons from rats and diabetic patients. This condition is associated with mitochondrial depolarization, ion pump dysfunction, and generation of reactive oxygen species. So when the mitochondria are unhealthy in neurons, they can't push sodium and calcium out, so there's constant pain activation, constant pain sensitization, sensitivity to pain. And this is part of the reason why when mitochondria start to fail, people start to develop pain syndromes and chronic pain all the time, and everything hurts. Now, here's a paper that was published titled Endoplasma, Reticulum, Mitochondria, Interplay of Chronic Pain and the Calcium Connection. They go on to show that emerging research also suggests that chronic pain associated with inflammatory diseases such as MS and rheumatoid arthritis may be linked to endoplasmic reticulum mitochondrial dysfunction. In all these pathologies, it is clear that pain is a major overlapping symptom. A common thread linking pain to these conditions is stress at the endoplasmic reticulum ensuing mitochondrial dysfunction and calcium dyshomeostasis. A better understanding of how disrupted endoplasmic reticulum mitochondrial interactions can lead to nociception. Better understanding of how disrupted ER mitochondrial interactions can lead to nociceptor hyperexcitability may provide insights into novel therapeutic targets that can be manipulated to reverse these the changes that have been sensitized to the system and restore homeostatic state. So it's the same thing. It's very clear that calcium dyshomeostasis, the inability to push calcium and sodium out of a depolarized cell because of lack of energy from mitochondrial impairment, can lead to chronic pain and chronic pain syndromes. And then here you can see, when these neurons are constantly activated over a period of time, so you have neurons close to the threshold constantly activating pain pathways, and you have inflammatory responses, that you start to develop central sensitization, meaning if you activate a pathway over and over again, it gets more efficient. So if you're trying to learn how to dance and you twirl around, maybe the first twirl you do, you're all over the place and falling over. But if you do 1,000 twirls, you get smoother and smoother and smoother and smoother. And eventually it's just very easy for you to do because those pathways become connected. And if they were to actually measure the neuron connectivity of the pathways involved with you twirling around and spinning, they would have more connections and more connectivity there. That's the concept of neuroplasticity. Well, neuroplasticity can also be negative, and that's termed negative plasticity. When activating a pathway over and over again gets more efficient, but it causes an adverse symptom. So you can have pain develop to neuroplasticity that then leads to efficiency of that system. So if you constantly fire your pain pathway over a period of time, these pathways for pain perception get to become more exaggerated, more efficient over time. So as neurons get close to threshold, neurons are constantly firing more, and then their postsynaptic pathways constant activation, and now you get central sensitization, where this neuroplasticity, development, and connectivity of those pain pathways continue to get more efficient, causing greater pain and greater degrees of suffering, nociception perception with people that are dealing with mitochondrial impairments. So this is a paper titled Chronic Pain, the Role of Learning in Brain Plasticity. They go on to show that based on theoretical considerations and recent observations, we argue that continued suffering of chronic pain is clearly dependent on the state of motivation and emotional mesolimbic prefrontal circuitry in the brain. The plastic changes that occur within the circuitry in relation to nociceptive inputs dictate the transition to chronic pain, rendering the pain less somatic and more affective in nature, meaning the brain is now sensing pain because it's more efficient, even though there isn't as much tissue distortion. That's plasticity, negative plasticity. So the brain changes. I'm going to show you a lot of cool research tomorrow on central plasticity, what happens to the brain. There's definitely changes in the brain immediately with pain, and then if that pain is continued on, the brain can continue to develop this negative plasticity response, and then a person no longer has to have an injury to constantly feel pain. And the start of all this is mitochondrial impairment. So as energy levels drop, these mechanisms get into place. Now you're dealing with chronic pain syndromes. So when someone says to you, low energy, I have low energy, one of the consequences of that is they can start to develop a pain syndrome when they get injured. And this is not a good thing to develop, okay? Now, in this paper that's also in your course materials, they just show these pathways, nociception coming in, these green arrows here, really developing plasticity in these areas of the prefrontal cortex, and then the limbic system, and this is all associated with emotional suffering of pain. So these just become very, very efficient over time. And then in this paper titled Understanding the Role of Mitochondria in the Pathogenesis of Chronic Pain, they go on to show that mitochondrial dysfunction contributes to the etiology of pain. It is suggested that mitochondrial energy generating systems and mitochondrial reactive oxygen species play the most important roles in the pathogenesis of chronic pain. Protecting mitochondrial function would be a promising therapeutic strategy to alleviate or prevent chronic pain states. So listen, if you're a practitioner and you have chronic pain patients, whether it's fibromyalgia patients or ME/CFS patients or patients with chronic pain with unknown etiology, you're going to have very limited effects with any intervention unless their mitochondria become healthy. So all the strategies we talked about getting mitochondria healthy could be huge. You could have someone who has neuropathic pain. Let's say they had a crushed nerve injury in their hand from occupation, or they had a herniated disc and injured their L5 nerve root. Now the disc is healed, there's no more pressure on the nerve, now the crush injury is gone, but they constantly have burning and pain, they can't function. You may go in there and switch them into a ketogenic diet, get fuel to their system, put them on nutraceutical support to bioenergetics, get them to sleep properly, get them to have a normal circadian rhythm, and you may cut down their pain dramatically from those interventions because you're improving their mitochondrial function. So that's the implementation of this information. It's not just about energy, it's also about pain. So even if you're dealing with really severe chronic pain patients, you have to know the only way out for these patients is by improving their vicious cycle of low energy. And this is a paper titled Metabolic Connections of Inflammatory Pain, Pivotal Role of Pyruvate Dehydrogenase Kinase Lactic Acid Acidosis. And they basically show that, for some people that have these inefficiency of producing pyruvate into lactate, like we talked about, this Warburg effect, they have increased lactate, increased activation of inflammatory pathways from lactic acid. This causes pain sensitization. Then they get negative plasticity. Their pathways to their spinal cord and spinal cord become much more efficient generating pain. Then these create pain in the brain, and then you have brain plasticity there. And this is basically fibromyalgia right here. Fibromyalgia, inefficient muscle metabolism, nociception pathways, and then centralization of pain. This is, a very, very clear mechanism that has been established. Now, in this paper, they go in there and they look at glial cells and how they react, and they use the dichloroacetate, which is one of the supplements you can use for pain, for the Warburg effect. And they go on, our work reveals changes in spinal cord mitochondrial function in persistent inflammatory and chronic neuropathic pain models. We also demonstrate that by targeting PDK, PDHC axis with short-term oral dichloroacetate administration after injury, mitochondrial bioenergetic parameters improve, glial reactivity in the spinal cord is reduced, and most importantly, it can be effective in ameliorating pain-related behavior in both pain models. So they basically went in there and shifted the Warburg effect to reduce pain, right? Very important. And then here's another study where they look at neuropathic pain, And they go on to show that neuropathic pain affects the physical and mental health status of patients due to its complex pathogenesis and adverse reactions to medicines. Its treatment remains challenging. Among all the etiologies, increasing evidence is pointed to mitochondrial dysfunction. They go on to show that DRP1 mediated mitochondrial fragmentation leads to excess reactive oxygen species, which is implicating the pathogenesis of neuropathic pain. So if they can't activate clearing of these mitochondrial fragments, fission, then that increases pain. And how do you get rid of mitochondria that's fragmented? Mitophagy. How do you get rid of that? You sleep. You get into deep REM sleep so you can activate those metabolic pathways. So, these are showing that when this fission pathway is not working well, they can't get rid of these fragmented pathways. These fragmented pathways lead to mitochondrial dysfunctions. They take up that real estate where healthy mitochondria can go, and this perpetuates the chronic pain pathway. Now, this was a review paper called Neuropathic Pain Dysfunction of the DRP1 Mitochondrial and RLS Homeostasis. And one of the things that they go into and discuss here are mechanisms that really impact preserving mitochondrial health to alleviate hyperalgesia. So first of all, there's some medications that impact these DRP1 pathways, inhibitors. They found that those things may have an effect. But they have found, number 4, melatonin. Melatonin modulated calcium efficiency for mitochondrial function has a direct impact on impacting vision. And melatonin also, remember, helps with the Wahlberg effect, and that can increase mitochondrial function, reduce pain. Hyperbaric oxygen improves blood flow and mitochondrial function. They also found ketone bodies reverses abnormal mitochondrial morphology. So fuel to the mitochondria actually changes mitochondrial integration and reduces pain. So not only that there's links with mitochondrial imbalances causing chronic pain, but when they do interventions to improve mitochondria function, it does change pain. So this is one of the things you have to look at. See, the problem is most healthcare practitioners, they see a patient chronic pain and they go, they need anti-inflammatories. Let's get them on, NSAIDs or acetaminophen or aspirin or Tylenol or opioids. And opioids actually sensitize pain pathways to make people worse. Opioids promote negative plasticity. They actually make all chronic pain symptoms worse, well established in the literature. It's a failing model. And then you have people that do nutrition, they go, well, anti-inflammatories, we'll just use turmeric, we'll just use curcumin. And those things are okay, and they have some benefits, but it's really changing mitochondrial homeostasis that gets rid of chronic pain. That's why getting into deep REM sleep, having circadian rhythms, having proper fuel energy sources, having proper oxygen, making sure they don't have any asthma or respiratory issues, make sure they're not anemic. Those are the things that actually change chronic pain patients. And it's not inflammatory necessarily, it's just energy. So this is what you have to kind of think about if you don't understand that these new concepts are new to you. Change your protocols from chronic pain to just being anti-inflammatory to being mitochondria supportive. Here's another study, supplementing with CoQ10. This is a double-blind study, placebo-controlled crossover trial, 11 fibromyalgia patients. Supplementing with CoQ10 effectively reduced greater pain, anxiety, and brain activity associated with pain perception, mitochondrial oxidative stress and inflammation. CoQ10 also reduced glutathione levels superoxidase in fibromyalgia patients. So they found that just giving them CoQ10, simple intervention for the mitochondria, had a significant impact on their pain and also their inflammatory response. So not treating pain with an anti-inflammatory model, but treating pain with a model to improve mitochondria. And this was another paper titled Pain and Death, Neurodegenerative Disease Mechanisms of Nociception. They go on to say that important clues to cellular mechanisms of neuropathic pain may be found by a close examination of neurodegenerative diseases in which neuropathic pain is often an underappreciated but important clinical manifestation. This approach identifies specific mitochondrial and cytoskeletal mechanisms previously implicated in the pathophysiology of neurodegenerative diseases in the central nervous system that might contribute to neuropathic dysfunction in peripheral sensory nerve fibers. So they go on to show is this. The mechanism of neurodegenerative diseases like dementia, Alzheimer's, Parkinson's is really associated with mitochondrial impairment and then protein aggregation in the brain, right? Mitochondrial impairment and beta amyloid buildup is Alzheimer's disease, right? So alpha-synuclein, Lewy body diseases, Parkinson's disease, they all have the protein aggregation and the mitochondrial impairment. So they're saying when people develop centralized neuropathic pain, it's very likely that their brains are already neurodegenerating, that they already have some of these mechanisms there that are unhealthy. And that's a key point. When people have mitochondrial impairment in the brain, they're not only going to have focus, attention, concentration, and brain endurance issues, they actually have the exact mechanism of neurodegeneration taking place. All they need is now an insult, an injury, and pain, and now they have a chronic pain syndrome. So that adds to it. So they go on to show, like here's, when they're looking at neurons, that these degeneration, like there's a very thin line between normal neuropathic pain, hyperactivity, chronic pain syndromes, and neurodegeneration, that the mechanisms are really overlapping between each other. And then if they look at the mechanisms and functions of ATP and painful neuropathies, they're pretty much identical to neurodegenerative diseases. And there's that overlap between these two conditions. So when people develop centralized pain, it's a suggestion that they may have some early types of neurodegeneration patterns, right? Because not everyone who has chronic pain develops centralized pain, but some people do. So here you can see illustration of these mechanisms. So you have mitochondrial impairment for whatever reason, so there's less ATP. Less ATP means the sodium-potassium pump and calcium pump are unable to restore sodium-calcium levels, intracellular levels. Neurons are close to threshold. That then causes sensitization, peripheral sensitivity to nociception, that's the peripheral nerve going to the spinal cord, and then central sensitivity to nociception, that's the brain developing negative plasticity. This causes chronic activation of nociception over time. You have central pain syndromes. So at the receptor site level, mitochondrial impairments bring neurons closer to the threshold, and at the neuron level, at the peripheral nerve and at the spinal cord, at the brain level, these neurons are close to threshold. It's part of the neurodegenerative mechanism that then increases depolarization and firing and suffering sensation. And then mitochondrial impairment here also impacts reactive oxygen species. Those can turn on the Warburg effect, increase lactate, increase reactive oxygen species. Those turn on neuroglia, there's inflammatory responses. The neuroinflammation promoted by neuroglia can increase pain from mitochondrial impairment. Then damage to mitochondria increase fission responses to remove injured parts that also increase reactive oxygen species. This causes surrounding inflammation and pain. So like once mitochondrial impairment takes place, it's very easy to develop chronic pain syndromes and ongoing chronic pain. And if you develop a chronic pain syndrome, you're not going to get out of it with anti-inflammatories necessarily. You may have to get out of it through improving general mitochondrial health. So key concept. Mitochondrial bioenergetics efficiency prevents hyperpolarization of nociceptors and the development of chronic central pain syndromes. And also, mitochondrial bioenergetic health prevents increased production of reactive oxygen species, leading to inflammatory responses in tissues. So I hope you can see these overlaps between fatigue and pain. This is why these are the two most common chief complaints in clinical practice. What they're really telling you is their mitochondria is failing, and whatever they're doing with their lifestyle is impacted. Maybe they do have too much inflammation. Maybe they don't have enough antioxidants. Maybe they're sedentary and not getting enough movement. Maybe their circadian rhythms are off. Maybe they're not really getting deep sleep because they're getting up 4 times a night to go to the bathroom. Maybe they have a chronic hypoglycemia. They just don't understand having smoothies all day and no meals in between is a problem for them because they think fruit's good and why don't I have more of it? They don't understand why they're degenerating away and getting tired. And then they walk into the healthcare system looking for a disease and they don't have a disease. And then they're frustrated. Then they get an injury. Now they have a chronic pain syndrome. Now they're not moving. So now mitochondrial biogenesis is off. And then the vicious cycle continues and you see someone who had a vibrant, healthy life decay away to really losing their motivation, drive, ambitions, and goals because of these pathways that are so important. As clinicians, we want to be able to figure these things out, find these things, and then work them through with the patients, and it may take some time to work through. Now, just like fatigue and pain, another thing associated with mitochondrial impairments, which involves the third most common symptom why people seek healthcare professionals, besides fatigue and pain, is depression. Depression is linked to mitochondrial impairment. Simply put, if you don't have energy for your brain gets depressed. So what they do in animal models, they put animals in small rooms where they can't move and activate, and they get depression. And that's animal models of inducing depression. So it's just lack of activity. When you don't have activity, you don't have mitochondria. Over a period of a few days and even longer, the brain's mitochondrial levels drop when they put an animal in a cage and they can't move. And they think it's lack of stimulation, but it's not lack of stimulation. It's that they're no longer having mitochondrial biogenesis. And now they have severe depression, and they study what drugs can help that. The bigger issue is how do you improve the mitochondria and don't put them in a sedentary lack of activation model. So this is the paper titled The Many Faces of Mitochondrial Dysfunction in Depression from Pathology to Treatment. Preclinical and clinical studies together with various meta-analyses and systematic review strongly underline the role played by mitochondrial reactive oxygen species, reactive nitrate species, metabolism, and oxidative stress in depression. So what they really find is that when they look at the mechanisms of depression, that the neurotransmitter model is really not the main model. The neurotransmitter model is something that was really popular because of pharmacology, but really what's happening with people that have really chronic depression and they really examine their mechanisms, that their mitochondria are becoming unhealthy. There's so much inflammation in their brain, and this is the inflammatory model of depression. But the inflammatory model of depression leads to mitochondrial impairment and mitochondrial damage. And over a period of time, their frequency of firing of their brain changes, the metabolic activity of their brain changes, and then this leads to all types of mood disorders and depressive disorders. And guess what the number one treatment is for depression? Like what's been shown clearly in studies to impact depression better than any antidepressant? Movement, exercise. So think about this. In animal models, they can stop movement, get the mitochondrial biogenesis to shut down, they get massive depression. And then all human studies, if someone is depressed, put them in a physical exercise program and depression goes away. And then why do we jump to neurotransmitters? And then why do we jump to, let's give them 5-HTP or tryptophan for their depression? Why not just fix their mitochondrial issue? It's just like the wrong model. And I think a lot of times we do green pharmacy. We see what the drugs are and we look for natural alternatives. But rather we should go deeper, look for these mechanisms for depression. Many of them are just the brain doesn't have fuel. There's too much mitochondrial demise. There's too much inflammation that are impacting these pathways. Now, this is another paper that was published, Targeting Inflammatory Mitochondrial Response in Major Depression, Current Evidence and Further Challenges. And they go on to say that studies have found that depressive patients usually exhibit altered inflammatory markers, mitochondrial membrane depolarization, oxidized mitochondrial DNA, and that's high levels of both central and peripheral reactive oxygen species. So study after study after study shows these are the mechanisms involved in depressive patterns. And then another review paper that was published, The Role of Mitochondria in Mood Disorders from Physiology to Pathophysiology Treatment, they go on to show that several studies have found a relationship between mitochondrial dysfunction and mood disorders, such as major depressive disorder, bipolar disorder, impairments in energy production are found in these disorders together with higher, less oxidative stress. See, we want it to be like depression is, you just need to take some things to raise your dopamine or things to raise your serotonin, or maybe all of them. And those have some effect because when you give someone a neurotransmitter, what do you do to the neurosynaptic cleft? You increase activation. If you increase activation, you build some mitochondria. So it has some side effects of that, but it's very inefficient. Other strategies to improve mitochondrial homeostasis, like we've been going over, can be much more effective in helping with major depressive disorder and pain and energy. Now, we also know that there's these neuroinflammatory responses and mitochondrial relationships with the neuroglia. And within the neuroglia itself, if they have lots of energy, the neuroglia can gate their inflammatory response. But if their mitochondrial levels are impaired in the neuroglia, that they lead to very exaggerated inflammatory responses and make everything much, much worse when it comes to the brain. And increased inflammation in the brain leads to decreased nerve conductance. Decreased nerve conductance leads to decreased postsynaptic activation. And decreased postsynaptic activation leads to inability to have mitochondrial biogenesis. So you have this vicious cascade. Once you have some degree of mitochondrial impairment, you're prone to a pro-inflammatory pathway. Then the pro-inflammatory pathway leads to pathways that then further uncouple mitochondria. So you need to like reduce the inflammation, improve mitochondrial health, activate the brain to get out of these pathways. Vicious cycles. So here's another study. Dysfunctional mitochondria decrease the pool of available ATP, which could have detrimental effects on signaling transduction pathways, dampening activity in neuronal circuits, and interfering with mitochondrial fusion and fission. The negative cascade will ultimately increase oxidative sites, stress, inflammatory responses, and pro-apoptotic events, some of which are known to involve the pathogenesis of depression. So again, mitochondrial impairment is key. There's inflammatory pathways that really can get impacted by these types of things. So this is just a video. It just shows you, just an illustration. There's no sound on this. It's just an illustration. Here's a neuron synapsing that's normal. And then in neuroinflammation, everything just gets slower. So normal, boom, synapse, and then everything gets slower. And if everything gets slower, then there's less activation. And if there's less activation over time, there's less postsynaptic activation of mitochondria, and then you start to have mitochondrial impairment and lack of biogenesis. So they've actually shown specific studies where mitochondrial impairment then leads to exaggerated inflammasome activity, and these inflammasome activities can actually disrupt things like serotonin physiology. This is a paper you can read. It's very biochemically detailed if you want to go into that pathway, but it's there if you choose to go in that path. It's there for you. And then mitochondrial health is also just critical for making neurotransmitters. The amount of mitochondria you have can have an impact on how much neurochemical activity you actually have in your brain. So in this scenario, you can see mitochondria that are not really functioning well and healthy. They kind of donut together. But these normal healthy mitochondria work, and you have more neurotransmitter response here than here. So again, cognitive function, neurotransmitter activity is related to mitochondrial health. And then same thing in the brain here, normal physiology, and then with depression. So this is a review paper specifically on mitochondria and mood. We reviewed all the main scientific papers in the literature relating to mood and depression, and then they summarized all of them in this great diagram. And they basically showed how important the link is between alterations of seen mitochondria in research and then chronic major depressive disorders and mood imbalances. So it's not a theory, it's a mechanism that's clearly understood. And then they've done the same thing with anxiety. They found lots of research with anxiety and mitochondrial impairment and bipolar disorders and mood disorders. And here you can see like an illustration of how these things work. Mitochondrial impairment increases reactive oxygen species, activates neuroglia, neuroinflammation, decreases nerve conduction speed, disrupts neurotransmitter pathways, depression, mood, and anxiety, and then less ATP, decreased ability to synthesize and release neurotransmitter, decreased neurotransmitter activity in the synaptic cleft, and then mood, depression, and anxiety. So when we see like a kid with a anxiety, or a person or a child with an anxiety disorder, a mood disorder, a major depressive disorder, we're not treating them the right way. We're trying to play the end game. We're not going far enough upstream is to impact the mitochondria. There isn't, one single thing that's going to have an impact here. You have to try to get homeostasis back through all the different things we talked about: fuel, oxygen, activation, things that impact mitophagy, clearance. Those are all the key things. So literally with some of these people that have chronic major depressive disorder, you go, hey, I got to get you out of this. We got to get your fuel efficient. We got to first stabilize your blood sugar level. We got to get you to sleep. We got to do all these tricks to get you to sleep. We got to get you on a regular schedule. Then we got to get you to move. And then there you go. And that's how you get them out of it. It's not like playing 5-HTP, then tryptophan, and then a natural botanical to raise dopamine and all these things. That's a totally failing model. Okay? So those are some of the relationships with the three biggest complaints: fatigue, depression, and pain linked to mitochondria. But wait, there's more. Mitodysfunction is more than just fatigue, depression, and pain. And this is really important. So really what they find is when people start to have fatigue and energy issues and mitochondria issues, they're really on their way to illness. They're really on the way of becoming sick. So they go on to say, I'm not going to read the whole thing to you, but they basically say that mitochondria impairment really is a key factor in the myriad of diseases of neurodegenerative mechanisms and metabolic disorders. This is a review paper. It's in your notes. You can read it. And then they start to show that, when mitochondrial levels are imbalances and these things really have a significant impact on signaling pathways. Remember, the mitochondria is involved with signaling pathways, and these really promote increased inflammation, impact the immune system. They really promote the pathophysiology of chronic diseases, and these can include not just chronic inflammation, but neurodegenerative diseases, cancer, rheumatoid, which is autoimmune, and then metabolic disorders. Remember, the mitochondria doesn't just make energy, but also involved with signaling pathways. So these signaling pathways are critical for mitochondrial function. And this paper has shown that these mitochondrial impairments are beyond just pain, depression, and fatigue, that they're really the key mechanism of whether and how fast you age, your cardiovascular health, cancer, inflammation, and neurodegeneration. This paper was titled Mitochondria at the Crossroads of Physiology and Pathology, published in Journal of Clinical Medicine in 2020, a recent paper. Really good review of the literature on this. And here's a paper that really shows all the different bodily systems impacted when mitochondria levels get impaired. So when you notice fatigue, you have to figure out how to change that, because this is then impacting resiliency and how these things impact human health. I'm going to skip this one and just get into neurodegenerative disease. So no surprise, mitochondrial impairments lead to neurodegenerative diseases. So when mitochondrial levels become impaired, there's inefficiency to clear out these accumulated protein aggregates like beta amyloid plaque in Alzheimer's disease. These beta amyloid plaques then create a vicious cycle, because then they uncouple the mitochondria, and then the mitochondria starts to degenerate. And when the mitochondria starts to degenerate and these plaques get in the way, neurons can activate each other. And when neurons can activate each other, that's where you get atrophy. This is part of the reason why Alzheimer's brains shrink, because the amyloid plaques that are there can't be removed. Part of it is because they don't have healthy autophagy and ATP-driven pathways. Then as mitochondria gets disrupted and there's less activity to neurons, those neurons start to degenerate because you need activation to keep neurons healthy. And then you get this atrophy response. And this is just an illustration of how nerve cells are really maintain their health with mitochondria. So you've got to have healthy amounts of mitochondria working to really make a neuron work. And this is a paper where they illustrate, when you look at aging, you get mitochondrial dysregulation. This then leads to metabolic alterations, increased inflammation, less fuel, neurons start to fire, and then dementia promotion. So dementia promotion starts with, I'm tired. And then it gets worse with, I can't focus anymore. And it gets worse with, I don't have as much brain endurance. Then I can't remember small things. And then I can't remember where I live. It's a progression. So these are all clear. They're happening in a linear fashion. It's just problems are just getting ignored. So this is the vicious cycle of free radicals, because when you have functional mitochondria and things are working well, you do produce some reactive oxygen species as part of a normal response. But once you get past the line and you get enough mitochondrial degeneration, you do create a vicious cycle. This is where you get perpetuated, accelerated aging. Not to say that can't be changed, but it does speed up. So once you have some degree of mitochondrial demise, everything speeds up much faster. This is why some people reach a certain age, like never the same at 50, never the same at 60, never the same at 40. These are part of these vicious cycles then turning on. So we don't just have fatigue syndromes, pain, and depression. We also have neurodegeneration that takes place when mitochondrial levels are impaired. And the basic model is this: decreased ATP means less autophagy, clearing out protein aggregates like beta amyloid and Lewy bodies and so forth. Decreased mitophagy to clear out mitochondria. Increased protein aggregation. Increased protein aggregates get in the way of normal neuron activation. Neurons have atrophy and death. That promotes neurodegenerative disease. Or as mitochondria get impaired, there's more free radical activity that's produced. They get greater neuroinflammation. They turn on neuroglia, and that speeds up the neurodegenerative process. It starts here. It actually starts with energy. And then we have mitochondria and cancer. So numerous studies on this. So this is a paper called Mitochondrial Dysfunction in Aging and Cancer, published in Journal of Clinical Medicine. And it was a review paper, and they go on to show that aging is a major risk factor for developing cancer, suggesting that these two events may represent two sides of the same coin. It is becoming clear that some mechanisms involved in the aging process are shared with tumorigenesis through convergent or divergent pathways. Increasing evidence supports the role of mitochondrial dysfunction in promoting aging and supporting tumorigenesis and cancer progression to a metastatic phenotype. So basically what they're finding is when you age, your mitochondrial levels go down, and then when they look at mitochondrial function in patients with cancer, this is a key determinant whether they have metastasis and have tumor growth. So there's some really shared pathways with aging and cancer, and mitochondrial DNA depletions, telomere shortening, and then dysfunction in the mitochondria itself are really involved. Remember that the mitochondria are involved with triggering the immune response, activating the inflammatory response, inducing the stress responses, all the things that are necessary to deal with malignancy. And the mitochondria, we know, is involved with helping get rid of viral infections and bacterial infections by activating inflammasomes that trigger the immune response. But in studies, when they look at tumor environments, and when mitochondria is not working well, proliferagenesis, blood flow to the tumor, and metastasis all go up when mitochondrial levels are impaired. So this is a paper titled Mitochondrial Reactive Oxygen Species in Cancer, and they show that mitochondria produce reactive oxygen species as a natural byproduct of electron transport chain activity. While initial studies focus on the damage effect of reactive oxygen species, the recent paradigm shift has shown that mitochondrial reactive oxygen species can act as a signaling molecule to activate pro-growth responses. So you need to have those healthy types of reactions to have some type of response. So there's this relationship between healthy mitochondrial signaling pathways and their ability to keep cancer cells at bay. This is a major area of cancer research at this time. And the summary is mitochondrial dysfunction decreases mitochondrial signaling. There's decreased inflammasome activation, increased activation of the innate immune system, which means cancer cells have a chance to grow and metastasize. And then dysfunctional ATP means decreased energy for immune cells. So then now your T cells and B cells and natural killer cells have an efficiency to fight the cancer. Then increased reactive oxygen species impact cancer proliferation, cancer angiogenesis, and metastasis. So now as we look at this, it's not just, fatigue, pain, neurodegeneration, mood, it's also cancer. They're all related to these mitochondrial impairments. But wait, there's more. It's lung disease. Lung disease directly related to these upstream processes. So when they look at airway disease and airway dysfunction, why do some smokers get COPD? Why do some don't? Why do some people smoke a cigar 2 or 3 times a day and have no problems, and some do? Part of it has to do with their resiliency. Part of that has to do with their mitochondrial function and how those mechanisms are in place. So in this paper called Mitochondrial Dysfunction Airway Disease, they go on to point that mitochondria can sense upstream processes such as inflammation, infection, tobacco smoke, and environmental insults important in these diseases, and in turn can respond to such stimuli through altered mitochondrial protein expression, structure, and resultant dysfunction. So basically, mitochondrial signaling is a key part of keeping these things in bay. Conversely, mitochondrial dysfunction has downstream influences on cytosolic and mitochondrial calcium regulation, airway contractility, gene and protein housekeeping, response to oxidative stress, proliferation, apoptosis, fibrosis, and certain metabolism, all which are key airways disease pathophysiology. So they go on to show that mitochondria, unrelated to energy itself, the signaling molecules that they produce really help keep pulmonary diseases at bay. And the healthier that a person's pulmonary mitochondrial status is, the more resilience they have for COPD or asthma or cigarette smoke impacting their health. And again, mitochondrial function is related to resiliency. Here they show health and resiliency to lung disease. And they show here healthy mitochondria, healthy amounts of mitochondrial reactive oxygen species, not too much, just the right amount of reactive oxygen species. Mitochondrial fission is working. There's mitochondrial damage underway, mitophagy is working, and then here they see, mitochondria being supported or dysfunctional. And the key thing is when they see mitochondrial disruption, dysfunctional mitochondria, that's when asthma really starts to pop out. That's when COPD really starts to pop out. So you just have to think of healthy amounts of ATP as resilience to the body for stressors. Whether the stressor is smoke or environmental pollutants or whatever the case may be, the amount of healthy mitochondria in tissues, like for example the lungs, can determine whether a person progresses into asthma or COPD. Runners, lots of oxygenation, lots of VO2 max, have healthy lung CO2s. Smokers don't. Sedentary people don't. So if you take someone who is a runner and has lots of lots of pulmonary mitochondria, and you take someone who is not a runner and you throw them into an area with air pollution, they're going to have different responses. So some are going to have resiliency towards it and some will not, right? So mitochondrial dysfunction, decreased mitochondrial signaling leads to cellular regeneration, decreases cellular regulation, and increased rate of oxygen species increases inflammation, fibrosis, cell proliferation, and then cellular insufficiency. These all lead to airway inflammation, airway fibrosis, and airway constriction. So that's another major pathway. So not just pain, not just fatigue, not just neurodegeneration, not just mood disorders, but lung disease and really most diseases, including, let's add to it, cardiovascular disease. So they find out once again, the healthier your heart mitochondria, the less sensitive you are to things that can injure the heart and cardiac muscle, and even blood vessels and plaquing and so forth. And here they go on to show that mitochondrial dysfunction decreases mitophagy, which leads to accumulation of cellular debris in the arteries that leads to arterial plaquing and cardiac fibrosis. So let me say that again. The amount of mitochondria you have in your blood vessels is going to determine how much plaquing you have. So think about a person who doesn't sleep, has an abnormal circadian rhythm, has a blood sugar issue for 10 years. They're going to have a different expression of changes in their blood vessels than someone else. Okay? Here you see reactive oxygen species, cellular inflammatory pathways. These promote plaque, promote fibrosis, decreased ATP causes tissue hypoxia. Just a summary of the papers that we went over. And then let's add more. There's more. Degenerative joint disease. These are linked to low mitochondria. So when they look at, for example, intervertebral disc degeneration, people that get a disc herniation or injure their discs, they find that growing evidence to suggest that mitochondrial function in intervertebral disc cells are severely compromised during the degenerative process of IVD, intervertebral disc disease. Dysfunctional mitochondria, along with impaired mitochondrial dynamics and mitophagy, cause a serious cascade of reactions that have been implicated in increased oxidative stress, senescence, matrix catabolism, and apoptosis of intervertebral disc cells, thereby contributing to the degeneration of intervertebral discs. And here you go. They illustrate this in the study where they're looking at disc degeneration with age. And guess what pops up? Mitochondria. The healthier the mitochondria in the disc, the less likely they are to have degenerative changes and degenerate away. So when you have people that have blood sugar instability, hypoxia, whether from anemia or from asthma or from poor circulation, they have increased free radicals, not enough antioxidants, they have abnormal sleep, they have abnormal circadian rhythms, they don't have enough nutrients to get to their mitochondria, they don't have any physical activity, mitochondria and all of their cells become impaired. And when mitochondria and all their cells become impaired, it just really promotes aging and degeneration, whether it's the brain, whether it's the arteries and blood vessels, whether it's the heart. And these are just more illustrations of some of the changes that take place with mitochondria disease and aging. And this is another paper that was showed like how important it is to have these mitochondrial functions there. And they go on to say like how how you treat degenerative disc disease, you fix the mitochondria. That's what you have to do. It's not just about anti-inflammatory responses. So when we look at the spectrum of all the things that start to take place with the mitochondria that's impaired, we have chronic disease. So this is how it starts. It starts like this. Patient has high energy, everything's fine, they're young, let's say everything's normal. Then they get a little tired. Then they notice just a little tired. Maybe they're getting a little bit of afternoon fatigue. Maybe they're getting a little tired after they eat. Then they get tired more often. Then they're tired all the time, and getting tired becomes normal. Then they get sedentary. Then they don't move. Then they have no movement, sedentary lifestyle, inflammatory issues, more oxidative stress. And now their brain doesn't work. Now they have depression. Now they have fatigue and depression. Now their body hurts. Now they have pain. Then they go into the healthcare system looking for help. And they go into conventional medicine. They go, well, you don't really have a disease. Maybe you need an antidepressant. Or they walk into a functional medicine clinic and they go, you need 10,000 nutraceuticals. We're going to ignore your sleep. We're going to ignore your blood sugar. We're going to ignore these other things. We're going to just work on your gut. And they're going to give you a probiotic and the 5R program. And it's like, those are all failing models. So that fundamental chart of how important it is to get fuel to the mitochondria, how important it is to get sleep, how important it is to get movement, how important it is to get circadian rhythms are huge deals. And, I hope, if anything, out of this course, even if it doesn't directly impact your practice, hopefully it directly impacts you and you can take a step back and what's your energy level. And see if in the next month you can increase your energy level. See if you can find little few things in there that can change your energy levels. Maybe you're just not sleeping through the night. Maybe you wake up twice in the middle of the night to maybe urinate, or maybe you're a sensitive sleeper, maybe using a weighted blanket, maybe using some slow music to help you sleep can make a big difference for you. Maybe taping mouth so you have nasal inspiration makes a huge difference. Maybe getting more consistent on movement and activity can change your energy levels over a period of time. Maybe you have to focus more on some foods that you're sensitive to. But as you increase your energy levels, what you have to realize is it's not just your energy level, it's really reducing your risk for all these other things. And at the end of the day, when we look at these lists of disruptive versus supportive bioenergetic pathways, they have a far-reaching effect. And ultimately, when we remove things that impair it and optimize things that enhance it, we're really building resiliency. This is one of the first slides I showed you. And the more energy a person has, the more efficient bioenergetics a person has, the healthier their brain. The healthier their brain, what does that mean? It means they can do things they want to do. They have goals in life. They have things they want to accomplish. You can only do that when your brain's healthy. You can't do it down here. Right? So your ability to accomplish your life goals, to be highly efficient, do what you want to do, starts with having energy to do it. Okay? The ability to be active and go for a hike and do things. The ability to recover if you get an injury. And the ability to reduce risk. These are all related to the efficiency of your bioenergetics. Your bioenergetics can change based on how it's treated. Right? So, again, fuel, sleep, movement are the key things everyone knows, but it's the implementation issue that's the problem that we have. And not just conventional medicine, but even within alternative medicine, even within functional medicine, we have these issues. We're so used to doing green pharmacy and building up people with supplements and not really addressing those underlying issues. So the takeaway message is really that when I want you to have two takeaway messages. One is for you and your family. What's your energy level? What can you do to optimize it? Think of some strategies that you can take away from this course. Optimize your energy, improve your brain function, improve your health, achieve what you want to achieve. And then for your patients, you have to make these connections. If you're working with chronic pain patients, you're not going to change your chronic pain until you improve their bioenergetics. It's that simple. You put them on all these anti-inflammatories, it's not going to be enough. You're going to have to go more. If you're dealing with people that have fibromyalgia, same thing. You're going to have to treat their bioenergetics. If you're dealing with patients that are suffering from major depressive disorders, chronic depression, you're not going to fix it with the neurotransmitter model. You're going to fix it by improving their bioenergetics. If you're dealing with children with neurodevelopmental disorders, ADD, ADHD, autism, dyslexia, the brain's not developing. Why do you think the brain is not developing? Why do you think the brain doesn't have the potential to develop? They have a mitochondrial impairment. They can't get there. You got to find out what those triggers are, remove them. So this is where these applications come in. You know, the problem we have is we have books where it goes disease, nutraceutical, disease, treatment, and those are totally inefficient. So you got to know what your battle is. For sure, fatigue issues, chronic pain issues, major depressive disorder issues are the big ones that are going to pop in that are screaming for you to do a very thorough mitochondrial workup. So that's the key concepts I wanted to get across with this presentation. Thank you.